Good day, everybody. This is Chris, the Ancient Scholar, and hopefully you are all having a great spring break, or you have had a great spring break if you're watching this video after spring break. So what I'd like to do today is I'd like to talk about a specific type of toxicity now, and maybe I'll do several videos talking about several common medications and substances that people overdose on. This tends to be one of the most common substances that is overdosed on, at least in the western part of the world, the United States, and I suspect that the prevalence of this toxicity is incredibly high in Europe as well. I'm not as confident in some other countries. I suspect there are certain other countries where perhaps certain types of insecticides are going to be more commonly overdosed simply due to their availability. But this particular substance is highly available in the westernized countries such as the United States. And this substance, of course, goes by the generic term acetaminophen, which is the common generic name is acetaminophen. I'll just write that up. All right. Acetaminophen. For my friends and for people who may be overseas watching this, paracetamol is the generic term used in many of the European countries, South Africa. So acetaminophen / paracetamol. The common trade name for acetaminophen / paracetamol in the United States, at least, is Tylenol. Tylenol is going to be the really common trade name that you're going to run into in the United States. So what is acetaminophen? Well, the chemical name for acetaminophen is N-acetyl. So let me break this up here. N-acetyl para. I'll write that there. Para-aminophenol. Aminophenol. N-acetyl para-aminophenol. This is kind of a pain to say all the time, so from here on out I will be using the common abbreviation for N-acetyl para-aminophenol, which is APAP. That tends to be the common abbreviation for this. Okay, so this is very common. It's an over-the-counter medication, and what is it used for? Well, it's primarily used for its antipyretic activities. Antipyretic, and to some extent it's analgesic. It's antipyretic and analgesic activities. It has very limited anti-inflammatory activities as well, and we'll talk a little bit about what's going on there. So how do we think it works? Well, we're not exactly sure how it works, to be quite honest. We do have some hypotheses, however, and the common hypotheses, we do know that it does inhibits the activity of prostaglandin. Okay, prostaglandin production in the central nervous system, which is going to be very, very important. That it does not have pronounced peripheral nervous system or peripheral effects. Excuse me. Its effects tend to be more central to the central nervous system, and this may explain how acetaminophen can have these antipyretic and analgesic effects, but have very limited anti-inflammatory effects. So, for example, if you sprained your ankle and you had some swelling, you may not really consider Tylenol a good option for treating that, because Tylenol has very limited anti-inflammatory effects. If you are wanting to take Tylenol, in lieu of something like ibuprofen, which has more anti-inflammatory activity. So something like a proper non-steroidal anti-inflammatory, such as aspirin or ibuprofen, is going to have substantially more peripheral anti-inflammatory effects than acetaminophen. And the reason that may be, we're not entirely sure, but the reason may be due to the fact that acetaminophen can focus on inhibiting the activity of the the cooxygenase 3 enzyme. And if you have studied anti-inflammatories, you're probably familiar with the COX-1 and the COX-2, or the cooxygenase 1 and the cooxygenase 2 enzymes, and how inhibition of those enzymes can inhibit prostaglandins, and those have pronounced peripheral effects when it comes to inflammation, when it comes to producing thromboxane and clotting factors, when it comes to producing the mucosal lining of the stomach, et cetera, et cetera, et cetera. However, the cooxygenase 3 enzyme may be more specific to effects within the central nervous system. So this may in part explain acetaminophen's very queer properties. It is a very interesting medication because it's really good at, it's very provincial in the way it works as far as antipyretic and to some extent analgesic activities, but not having all of the other anti-inflammatory activities that you might see with other what I would call true NSAIDs, non-steroidal anti-inflammatories. Okay, so let's go ahead and just talk about the basic pharmacology, or the pharmacokinetics and pharmacodynamics of acetaminophen before we move on. So acetaminophen is also very interesting when it comes to its pharmacokinetics. So when we talk about its oral bioavailability, its oral bioavailability is very high. It's exceptionally high. I'm talking 60 to 95+%. Okay, so depending, on if you had a lot of food to eat or whatnot, you can have oral bioavailability approaching 100%, which means that pretty much every milligram of acetaminophen you ingest does have a chance of making it into your central circulation. If the acetaminophen is given as a suppository, which is not an uncommon way of administering it, if it's given rectally, PR, per rectum, we can expect a bioavailability of approximately 40%. So significantly lower, but still a fairly good bioavailability at the end of the day. All right, like I said before, it does have antipyretic or fever reducing and limited anti-inflammatory activity. When we talk about its peak concentration following ingestion is going to be so its peak plasma concentration is going to be approximately 1 to 4 hours. Some people may say 1 to 3 hours, but right in that range, a few hours for peak. And acetaminophen has very low plasma protein. Has a very low plasma protein binding, only about 30%. Only about 30%. So its bioavailability, again, not its bioavailability. Excuse me. Its volume of distribution would also reflect this decreased amount of plasma protein binding, and that it's going to have I want to keep saying bioavailability. It's going to have a apparent volume of distribution that's going to more approximate a medication that is well distributed throughout a central body compartment. So it doesn't have a major sequestration like some other substances that may be highly lipid bound or highly protein bound. You're not going to see that with acetaminophen. Okay, so let's go ahead and talk about the metabolism of acetaminophen really quick, simply because this actually is a very important part of understanding what's going on. So let's talk about the metabolism. So if I have my parent molecule, my parent molecule of acetaminophen is going to look like this. It's a benzene ring as the central structure. I have a hydroxyl group here. And then I have a group that comes off of here, a nitrogen, hydrogen. Obviously, there's an amine group there. Carbon with a double bond to an oxygen up here, and then a methyl group here. Okay, and of course, this is a benzene ring, so I better put my resonance structure in there. I don't want to be called out by proper chemists. All right, so there are three different ways that acetaminophen can be metabolized. It is highly hepatic. It goes through high amounts of hepatic metabolism. That should come as no surprise because the liver metabolizes a whole bunch of medications. So there are three different pathways, if you will. There are three different pathways. Two pathways tend to be more common, and they tend to lead to conjugated substances that are either eliminated by the liver or eliminated in the urine. And about 25% of the conjugated metabolites will be eliminated in the liver, and then 75% will be eliminated in the urine. So the first thing that can happen is I can conjugate, and this is actually about 47 to 62% of my acetaminophen is going to be conjugated, and it's going to be ultimately eliminated as a glucocuronide, which, if you look at the structure of acetaminophen here, all right, I'm just going to put an R here, and that R just says that there's a whole group there. All I do is I replace this hydroxyl group here. It gets replaced, and I have a glucocuronide. I have a glucocuronide group attached to that, and then this can be eliminated fairly easily. This is non-toxic. This is a non-toxic metabolite. So quite a bit of the acetaminophen is eliminated this way. And then another 25 to 35% thereabouts will be eliminated as a conjugated sulfate compound. So if I have my parent molecule here, and instead of glucocuronide, I just have a sulfate. Group, and then this is eliminated. This is generally non-toxic as well. All right, so a majority of the acetaminophen is metabolized into non-toxic metabolites that are fairly easily removed, and that's a good thing. Unfortunately, there's another pathway. It's a minor pathway, but boy, is it important. The other way that we can do this involves our old friends, the cytochrome P450 enzymes. All right, the cytochrome P450 enzymes. The specific enzyme that's involved in the hepatic metabolism of acetaminophen is the cytochrome P450 enzyme, the 2E1 enzyme, and its isoenzymes. Okay, so it's the specific enzyme we're talking about is a cytochrome P450 2E1, and 2E1 will metabolize this acetaminophen molecule into a metabolite known as I'll go ahead and write this out, N-acetyl P benzo quinone imine. All right, so N-acetyl P benzo quinone imine which can be shortened to the metabolite NAPQI. That is the common abbreviation for that specific metabolite. This metabolite is toxic. This is a toxic metabolite. And there are one of two things that can happen with this metabolite, and it depends on what's going on. So the first thing that can happen, which is the thing we want to have happen, is we have glutathione. So we have glutathione. We have glutathione, okay, and I'm just going to abbreviate that GSH, glutathione. And glutathione can conjugate, okay, glutathione can conjugate with the NAPQI, all right, so I'll have a conjugation that can occur, and I'll just draw that R, and it's going to look something like this, and then I have my glutathione attached to the molecule, and if that occurs, no big deal. I can make non-toxic metabolites with glutathione glutathione conjugation, and I can eliminate this through cysteine, and let me spell that right, mercapturic acid. Capturic acid conjugates. And this is about 5 to 8, God, I'm just typoing all day long here, 5 to 8%, okay, 5 to 8% of the acetaminophen will be metabolized and ultimately eliminated through this pathway. Now, here's what we run into. If I get into a situation where I overdose on acetaminophen, and I'm making a whole bunch of this NAPQI, or I have some other situation where my liver, I have some underlying liver disease, or I'm a very heavy drinker and I have some liver insufficiency, or maybe even some sort of genetic liver disorder, whatever the case may be, my liver's not working as well, or I've overdosed on acetaminophen, I can become depleted. I can have glutathione depletion, and what will happen is if I don't have glutathione to conjugate with this toxic NAPQI, the NAPQI will begin conjugating with hepatic proteins and nucleic acids, and that is going to cause damage to our liver. That's going to cause hepatic damage, which may even lead to hepatic failure and hepatic necrosis. So that's a basic pathophysiology of acetaminophen toxicity. Is if I overdose on this, or I have liver disease and I take acetaminophen, and I overwhelm the normal glutathione mechanism, I deplete my glutathione stores, that NAPQI will begin conjugating with hepatic proteins, and that is going to lead to hepatic damage. Okay, so when we talk about that, when we talk about a situation where I have acetaminophen overdose or suspected acetaminophen overdose, what's going to happen? Well, there are some assessments. Obviously, your physical exam, your history, but there are going to be some lab tests that we're going to want to look at. And we can actually draw for acetaminophen levels. And the common thing that we can look at, the common thing that is used to determine whether or not we're concerned about toxic levels of acetaminophen in the body is what's known as a Rumack Matthew nomogram. That is the common way. The Rumack Matthew nomogram. All right, the Rumack Matthew nomogram. And the Rumack Matthew nomogram looks something like this. I have time here on the x-axis, and time is generally going to be in 4-hour blocks. It's going to start at 0, 4, 8, 12, etc. And then on the y-axis, it is going to be in micrograms per milliliter. That's the standard units we use in the United States. I should say to my friends overseas, you guys use SI units. That will be a different unit. So I would suggest, if you want to learn more about this, look up the Rumack Matthew nomogram using SI units. It's the exact same concept, but the values that you use are probably going to, they will actually be a little different. And Europe actually has slightly different thresholds for treatment than the United States. So this may not apply to you, but the concept of using a Rumack Matthew diagram is still valid. Okay, so remember when I said that the peak acetaminophen levels are about 1 to 4, 1 to 3 hours following ingestion. So what we'll do is, when we get somebody who's overdosed, we'll draw an initial level of acetaminophen when they enter the emergency room, and then we will draw a 4-hour level, 4 hours following admit, and that's the level that we will use to determine whether or not they need treatment. And so that's where we kind of kick this whole thing off here. And what we do, if you look at the Rumack Matthew diagram, there are 2 lines on it. There is a lower line, and it looks something kind of like this, and then there's an upper line, which will be my dotted line like this. Okay, and this is what's called the Rumack Matthew line. Okay. And basically what you do is you go to this diagram, you go, okay, what's my 4-hour level? And then I find the concentration here on the y-axis, and I go up and I go, oh, okay. And if the concentration is above, at this or above, there's a high likelihood of hepatic damage occurring. What we do as a margin of safety is we will actually put our treatment line, so the lower line is the treatment line. Our treatment line is approximately 25% less than the Rumack Matthew line, and that's just kind of a little wiggle room, a little margin of error. So our threshold for treating acetaminophen toxicity is actually 25% lower than the Rumack Matthew line. And the big thing to know here, this probably will show up on tests and whatnot, is at 4 hours, the common treatment line is going to be a value of 150, okay, 150 micrograms per milliliter. Micrograms per milliliter. Oh, I just used a non-standard medical abbreviation, MCG. All right, just forget I did that. MCG per milliliter, micrograms per milliliter. All right, and if you want to know more about this, you can just go online, look this up, and you can find a much better picture than I can draw here. But I just want to make you aware of what that is. Now, the major pitfall for this, however, the major pitfall for the Rumack Matthew nomogram is it assumes a single large dose. It assumes that your patient went home, swallowed a bottle of Tylenol, and then came to the emergency room. This does not necessarily account for comorbidities. It does not account for chronic overdose. People that use, perhaps they're not swallowing a bottle of Tylenol every day, but they're taking fairly significant doses, and they're doing this chronically, and they have chronic acetaminophen overdose. Those kinds of patients are very common, first of all, and deciding what to do with them using a Rumack Matthew nomogram may be difficult. And I would say, look, when in doubt, consult toxicology, consult poison control. The number's really easy to remember. It's 1-800-222-1222. 1-800-222-1222. So you can always call them. If you're working in a larger facility, you may even have a medical toxicologist um, that you can call as well. But poison control can be very helpful. They can help you make some of these decisions. All I'm doing here in this short video is just kind of giving you some basic high yield information, and then you will have some big decisions to make later on if you are working in a situation where you have to deal with these toxicities. Okay, so let's go ahead and talk about the presentation. So the classic presentation for acute acetaminophen toxicity tends to have different stages. And there are 4 different stages that we find that we can kind of divide this toxicity up. And again, this is more of an acute, large dose, what we see with progression. Chronic toxicities can be a little more difficult to kind of stage out and figure out what's going on. So stage one is generally considered 1 to 24 hours, the first 24 hours. And generally what you see here are non-specific signs and symptoms: nausea, vomiting, pallor, diaphoresis, malaise, just generally not feeling all that well. So non-specific signs and symptoms. Stage 2, okay, stage 2 is what we see from about 24 to 72 hours, so 1 to 3 days. Stage 2 is classified as the injury. This is the injury stage. This is where you are actually having hepatic injury. Okay, so you are going to have all of these non-specific signs, but you are going to have elevated hepatic transaminases. So your AST is going to become elevated. Your ALT is going to become elevated. Your bilirubin is going to be elevated. You may even have some coagulopathies beginning to develop, although those tend to be very ominous findings in early stages. All right. Then as we transition, we will go into the stage 3. Okay. So stage 3 tends to be 72 to about 96 hours post-ingestion. And this can be thought of as the necrosis. The necrosis phase. This is where you actually have full-on hepatic failure, and you have your classic signs and symptoms of hepatic failure. You have hepatic encephalopathy, your ammonia levels increasing, coma, nausea, vomiting, multi-organ failure. You become very jaundiced, etc., etc. Coagulopathies may develop, so your INR may be, your bleeding times will be prolonged. You may have depletion of clotting factors, etc. Things you'd expect to see with a significant hepatic necrosis. It may even be a fulminant presentation. And then stage 4 assumes that you've survived, and stage 4 is up to about 2 to 3 weeks, right in there. And this is what's classified as recovery. This is the recovery phase, and this is basically you have recovery from what happens here. You may or may not. How much you recover depends on a lot of different factors. So you can kind of think of it as I feel fine. Okay, you can think of kind of some Monty Python going in here. I feel fine. I'm sick. And then I'm dead, and then just pull some Monty Python there. I'm not dead. I'm not dead yet. So that's kind of the 4 phases that we see with acetaminophen toxicity. Now let's go ahead and talk a little bit about treating acetaminophen toxicity. So we talked about when we treat it, what we can expect, and how can we treat it, and how can we minimize the toxicity or even prevent the progression of acetaminophen toxicity. And some general rules of thumb, I'll just throw some numbers out there. People generally say, look, if you have adults that are taking more than about 75 milligrams per kilogram per day, or more than 4 to 6 grams in a 24-hour period, you're going to run into problems with potential toxicity. Children may be a bit more resistant to acetaminophen, and you may not see toxicities occur in kids until you're about 150 milligrams per kilogram per day and above. Some people even say up to 200. These are just really, really rough general numbers. And again, a lot of it, again, is going to be based on your 4-hour acetaminophen level and just what is your clinical presentation, your overall clinical presentation. So, what do we have that we can treat this with? We do have an antidote, quote unquote, and that antidote is known as N-acetylcysteine. N-acetylcysteine, or NAC, so we like to abbreviate it. In the United States, you should be familiar with this. This is a very common mucus breaking. This is a medication that we can actually nebulize, and it breaks up mucus. It's called mucolytic, and that is Mucomist. And I'll put a little trademark there. All right. Mucomist. All right, so N-acetylcysteine, or NAC, what does it do? Well, if we go back here, the basics of what it does, if I go back here, N-acetylcysteine helps restore glutathione. It helps increase, so if I give this, it will help increase glutathione stores, and when it does that, it can reactivate this cycle, if you will, and prevent hepatic damage. N-acetylcysteine has also been shown to decrease the progression of damage that is occurring, and may even be associated with helping with repairing, helping with hepatic repair. So its action is probably a bit more complex than just repleting glutathione, but that tends to be the major thing. Now, there are two ways that we can give N-acetylcysteine. There is the oral way. We give it orally, okay? And if you've given it orally, you know it's horrible. It smells terrible. It smells like rotten eggs. You give it, people tend to throw up. So I prefer not to, and I used to, because until fairly recently in the United States, we didn't have alternative ways of giving this stuff. So now we do, but back when I first got into nursing and was working in the emergency room, we were given this stuff orally, and it was just terrible. Terrible for the patients and providers and family members and just all parties involved. But if we're giving it orally, the general recommendation is to administer an oral loading dose of 140 milligrams per kilogram. All right, you give that, and then at 4-hour intervals, you administer 70 milligrams per kilogram times 17. And you do that for about 72 hours, monitoring your acetaminophen, your Tylenol levels, and monitoring how your patient's doing. Now, the new way of giving it, at least in the United States, is through intravenous infusion, which is really nice. The general recommendation is you give a loading dose, and you load them with 150 milligrams per kilogram IV. I think the recommendation is to mix it in 200 milliliters of D5W, give it over about an hour. Okay, following that, you will then administer a second load of 50 milligrams per kilogram IV infusion. You will give that over 4 hours instead of 1 hour, and then you will give a third and final load of 100 milligrams per kilogram IV, and you'll give that over 16 hours. Each of these will be that dose mixed in 200 milliliters of D5W. There are other ways that this may be dosed, and there may be intermittent schedules, and there may be different ways of giving it depending on chronic, acute, etc. This is not all-inclusive. This is just the common high-yield way of giving it. and I certainly wouldn't take my videos as medical advice per se. Obviously, you want to stick with whatever protocols and guidelines you have in place and whatever guidance you're getting from your toxicology folks. This is just a video to help you understand a little bit more about acetaminophen toxicity. It's very common. It's a big problem in Western society, so I think it's something that's very important to talk about. Okay, guys, as always, thanks for hanging in there.